Good afternoon, everyone. My name is Nicholas Toscano with SterlingRisk, and I'd like to thank you for attending our webinar hosted by SterlingRisk Insurance and Centivo. If you have questions, please feel free to use the chat function, and all inquiries will be addressed at the end of the webinar. In addition, the webinar is being recorded, and a link will be emailed to all attendees for future viewing. First, I'd like to introduce Mary Alice Nazarian, who is the president of SterlingRisk Employee Benefits. Hi, Mary Alice. Would you like to get us started?
Sure. Thanks, Nick. Good afternoon. I'm Mary Alice Nazarian, president of the Employee Benefits Division at SterlingRisk. Thanks for joining us today. I see some familiar names and clients on our guest list, so welcome. And for those of you that I have not yet been fortunate enough to meet, I wanted to give you a little background regarding SterlingRisk before I turn it over to Steve Jasinski and our partner Ashok at Centivo. SterlingRisk is a full-service brokerage firm. We were established in 1932, almost 90 years ago, and most of our growth has been organic. We have approximately 225 insurance professionals. Our corporate office is in Woodbury, Long Island, and we have sales and service offices in 8 locations around the country, providing for a national footprint. Well, I mentioned we're a full-service brokerage firm. In the benefits department, we view ourselves more as consultants due to the complexity of the current health insurance environment we're all living in. We work closely with our clients to help them navigate through all the state, federal, and ERISA regulations imposed on employers today. I always say, you know what you know what you don't know, but you don't know what you don't know. So that said, we work to limit your overall liability. We're constantly looking at new and creative solutions to help our clients reduce or mitigate their healthcare spend, while still offering the benefits that their employees have come to expect and deserve. Centivo is one of those solutions. So without further ado, I'm going to pass this webinar on to Steve Jasinski, our Senior Vice President of Sales. Thank you again for joining us. Steve?
Thank you, Mary Alice. Good afternoon, everybody. And as Mary Alice said, my name is Steve Jasinski, Senior Vice President of Employee Benefits here at SterlingRisk. And I also want to thank everybody for attending today's webinar. Just to piggyback off of what Mary Alice spoke of, SterlingRisk, our working philosophy is not just to be a broker or consultant to our clients, but to be an extension of their organization and their human resource and finance departments. And it's extremely important to provide the due diligence necessary to properly represent and partner with clients. So in addition to an extensive suite of services and resources that we provide, we also ensure that clients are made aware of all the options and strategies that can assist in successfully reducing their healthcare spend. That brings us to today. We recently partnered with Centivo as an important arrow in our quiver of cost-saving solutions for employers. Centivo is a TPA, a third-party administrator headquartered in New York City, but they're much more than just your average TPA, as they provide innovative and cutting-edge solutions for employers. With us today is Ashok Subramanian, CEO of Centivo, who will be discussing in greater detail what is collectively being accomplished to reduce employers' healthcare spend. Just a brief background, Ashok received his undergraduate degree from Princeton University, his master's degree from Stanford, and his MBA from the Stanford Graduate School of Business. Prior to Centivo, Ashok co-founded Liaison, the nation's industry-leading private benefits exchange for active employees, and Liaison was later acquired in 2013. In 2017, after observing the inefficiencies in the healthcare system and the pain that this resulted in for employers and employees, Ashok founded Centivo. So without further ado, I'm pleased to introduce Ashok Subramanian and Centivo. Ashok?
Thank you, Steve. Thank you, Mary Alice, and thanks to all of you for joining today. As I listen to your description of my bio, all I can think about is that I went to school way too long. So thanks for reminding me of that. But everyone, I'm happy to sort of speak to you about what we're seeing in the market and opportunities to help restore healthcare affordability for your workforce. I'm under no illusion, we're under no illusion that there's no one solution that's right for every organization. That's why it's so important to have a great advisor working with you to help you navigate your benefits program. It's as complicated an industry as there is in as complicated a time as we're all currently in today. And our partners at SterlingRisk are as good as it gets. So really pleased that many of you either are clients of or are considering working with SterlingRisk more closely. But with that said, what we have come to realize, and as I like to joke, I took the wrong turn at the career fair in college and have ended up in this healthcare business now for about 25 years. I've come to realize that the big carriers, United Healthcare, Aetna, Blue Cross, et cetera, they're hardworking, intelligent people there, but at the end of the day, they simply have not solved our problem. And if you look at this slide, it brings to life some of the challenges in a really stark way that many of you might be feeling in your own organizations or for colleagues and team members of yours. Half of America can't afford a $400 family emergency of any kind. Yet, based on data produced by the Kaiser Family Foundation, the average health insurance deductible for a family of four is 10 times that amount, that $400 amount that people can barely scrape by. Secondly, wages have effectively remained stagnant in this country net of inflation. Healthcare expenses have doubled. And while that's happened, insurance carriers have seen their stock prices grow at a rate about 1.5 times faster over the last decade compared to the rest of the stock market index. Again, we don't begrudge for-profit companies trying to make an extra couple bucks, but we do when we as employers have basically come to terms with the fact that open enrollment is the announcement of the annual pay cut at companies all across America. And employees are making choices, too many of them too often, between food and housing and medicine on a week-to-week basis. So with that, we tried to step back based on our knowledge of the industry, our relationships, and see if we could build a product to help achieve this mission of affordable, high-quality healthcare for those who struggle with their bills. The path that we are going to talk about today, the product that we have built, is one that is not invented in a laboratory. It's one that is based on actual results from employers and providers all across the country. And like with so many things, there often is a great deal of innovation amongst the very large companies. For example, Disney, with their 150,000 cast members and family members of their colleagues in Central Florida, they looked at their data, and their data showed that if you looked at the two healthcare providers in the Central Florida market, Orlando Health and Advent Health, that there were up to 40% differences in cost of care with no correlation to quality. The example you see here is for cancer, but there are tens, if not hundreds, of these types of examples. Other large companies, Boeing, Intel, General Motors, they similarly saw these types of patterns. High cost variation, no correlation to quality. We're going to share some information in the broader New York tri-state area market as well to bring this to life. But ultimately, what these large employers did was basically say the broad carrier networks who we had hoped would use their scale and their clout to try and lower costs for everybody instead had a fatal flaw. And what that fatal flaw was is that they had to be all friends to all people because they're in so many lines of business. They're in a Medicare business, a self-funded employer business, an insured business, and it was hard for them to pick and choose favorites. So what these employers did was say, we're going to take matters into our own hands and we're going to selectively negotiate with those providers of the highest quality who are the most cost effective. And what they then did is to make it really easy and simple for their employees. What studies have shown is that people are far more willing to listen to their doctors in terms of the advice that they get versus searching on websites or looking at other sources of information. So these large companies created a new model that aligns employers, employees, and select value-driven providers. And what we've done at Centivo is to bring that down to the masses. So you don't have to be Disney or GM or Boeing or Intel to be able to make such a model available. So if we go to the next slide, what we are is a new health plan. So if you think about what does a health plan do for you? A health plan pays claims. A health plan provides access to providers, and we're going to talk about different ways we do that. A health plan answers phone calls. A health plan provides an ID card that has the information on where a claim should be submitted. And a health plan obviously works to administer the benefit design and provide the support that you need as an employer. So we, as a TPA, to Steve's point, but a TPA that builds value-based networks, are a health plan that is specifically organized for self-funded employers and are anchored around those leading providers of value-based care, like the ones that those large employers have partnered with. And again, we're going to bring this to life for you in the tri-state area in a moment, since most of you are based here. We have 3 key principles to our programs. Number 1 is we design for affordability and quality with primary care at the front end. Most of the innovators in this space have used primary care as a way to drive value, and our programs are no different. Second, we built a solution that is intentionally designed to be simple. That's based on a lot of research that we did. The average American is sick and tired of trying to guess a deductible, a coinsurance, how much is 20% of some unknown number. What they wanted was simplicity, clarity, and the ability to always know how much a service would cost for them or for their family with no surprises. So we built a benefit design to enable that, and we'll show you how that works. And then lastly, we created some technology for folks who don't want to use an app or use a portal. You can always pick up the phone and call someone on our service team. But for those who want to and are comfortable using technology, the ability to see your claims history, see your care history, choose your primary care team, get a referral is all done very easily and simply on an app, which avoids a lot of the hassles that folks deal with today from a typical health plan experience. The other point that I'll make on this slide, and we'll get into more of the details, is our model is built to be completely different from a typical health plan when it comes to transparency of the money flow. Here's what I mean by that. A couple slides ago, we made the point that health plans are making more money as healthcare costs go up. Simply put, we think that's wrong. The analogy is like in the 401k business, when a lot of organizations were making more money by pushing high cost funds. That's been cleaned up over the years, where now you have independent administrators who are working for the employer, not for the fund manager. And those independent administrators are fully accountable to you as the administrator. In our model, what we do is we put our finances at risk. So we take upside and downside on our fees tied to your total cost of care. And that is a very important difference compared to the typical carrier today, who, as I like to say, unfortunately comes back most times, not always, maybe not in COVID years, but often comes back and says, we're sorry, your costs are going up. It's not our fault. Your people are sick, and here's your increase next year. We think it's important to take a much more accountable approach that is aligned with you as a true partner. So we're going to go into details on what does this actually mean and how does this actually work for the average employee who doesn't want to think about sort of healthcare economics at a cocktail party. So the basics of what we do is to find great provider organizations who hit some of the themes to drive that better value. What allows one provider to deliver cost-effective, high-quality care 40% less expensively than another right across town? And I'm going to share examples in this market. So these are some of the key characteristics. Focus on primary care, using technology, so all the information about a patient's in one place, building for access, the ability to get a patient in, get a patient out, using virtual care, having urgent care open and staffed until 12 midnight, like our partners at ProHealth on Long Island do. Having pediatricians available by text message, like our partners at Riverside Medical in New Jersey do and have done well before COVID ever struck. Experience and risk-based contracts. That's a bunch of fancy words to say these are organizations who have put their money on the line to deliver cost-effective care and are typically the highest performers in programs that make them take risk on their own dollars. So if we go to the next page, we now cover a footprint that by the end of this year, by the 1st of January, will hit about 16 of the largest metropolitan areas in the country. Obviously, we're going to spend a lot of time in this presentation on the New York market, but when I say New York or the Northeast, yes, Manhattan, Brooklyn, Queens are a part of it, but really it is going all the way up into Connecticut, out to Hartford, all the way down to Philadelphia. up into upstate New York, out east to Montauk. So it's a broad area covered by the Northeast. In Florida today, we're in Orlando and Jacksonville. In California, we cover the Los Angeles down through San Diego to the Mexican border, and you can see sort of several other markets that we're in. A common thread amongst all of these markets is an anchor partner relationship with a very high quality system, the type of system that we would be proud to have ourselves or our own family members get care from in a time of need. The example I like to use, I'm from Buffalo, you'll hear it from me a lot. Quarterback Jim Kelly, obviously in the Hall of Fame, he needed head and neck cancer surgery. He could have gone anywhere. He came down from Buffalo to Mount Sinai, had his treatment done by a world-renowned, oncosurgeon. That's an example of the kind of destination places that we build our systems around. In Los Angeles, UCLA, you might have heard, sadly, about Tiger Woods' recent car crash. He ended up at UCLA for a lot of his care. If we go to the next page, we're going to now dig into this market in more detail. And one of the questions that I know many of you are going to have on your mind is, well, what about employees of mine who live elsewhere? Or what about employees of mine who have family members that are in college or who really insist on having a network that includes some of the names not mentioned here? I'm going to get to all of those. So I just want to park that as a question because I know it's probably going through people's minds and know that we've thought about that and we've solved for that. But to do a deeper dive on our partners in the Northeast, the logos here are ones that are in our network. Typically, you'll find if you go to their website and look at the list of participating insurance plans, you'll see Centivo's name. And again, Mount Sinai is sort of that anchor partner from an academic medical center perspective, but some really high profile partners beyond this. So for those of you in New Jersey, Atlantic Health, parent of Morristown Medical, perennially rated the #1 hospital in the state of New Jersey. Valley Health in Ridgewood, perennially rated the #1 in Bergen County. If you go out on Long Island, our partner is with partnership with the Catholic Health System. In Connecticut, the New Vance hospitals, which are Danbury, Norwalk, Sharon, New Milford, as well as if you go into upstate New York, Montefiore, and several of the New Vance system hospitals there as well. So it's a strong network of hospitals, but beyond hospitals, we have about 25,000 participating physicians. I mentioned ProHealth, I mentioned Riverside. We have a number of other independent practices such as WestMed in Westchester County. And for other areas like urgent care, we have partnerships there as well that are independent and freestanding. For those of you who know CityMD, that's part of our network. Or if you're in Connecticut, AFC Urgent Care, part of the network as well. So it's built using standards to determine how do I make sure that every single type of care from routine to complex are all covered in the network, but is doing so in a focused, cost-effective way. If we go to the next page, the way that this drives savings, which we'll get to in a moment in black and white, is by #1, trying to get as much care possible into those cost-effective systems, kind of like we talked about in that example with Disney in Central Florida. We then negotiate more competitive unit costs. So we negotiate about 15% better rates compared to Blue Cross, United, and Aetna because of our relationship with these systems to help them get more traffic and to help them get full credit for what they have done to take the cost and waste out of their own systems. We then are able to get significant savings by using that primary care guidance model to make sure that folks are going to the emergency room less or having unnecessary specialist visits if it can be treated more inexpensively by the primary care relationship. And lastly, we provide all of our provider partners with a referral tool that allows them to make sure that anything downstream is actually going to the doctors that we would want them going to. So not the cardiologists that excessively use cardiac catheterization, which not only is expensive, but also could lead to complications and other challenges if not done correctly the first time. So it's a 4-part model that drives significant savings. And to get to 2 examples of that, if we go to the next page, this is based on our actual client data now going on about 3 years. where if you look at the average family of four, again, this is based on data from the Kaiser Family Foundation. It's a staggering number. You know, when I stepped back and our team did this, we had to do a bit of a double take. Is this real? Are these numbers right? And then you think about it and you look at your own accounting and it sure is. And frankly, in this market, it can be even worse than this sometimes. But the average family of four, if you add up the amount that an employer pays for their share of either premium or their share of the premium equivalent, if it's a self-funded plan, the amount the employee pays out of their paycheck, and then the amount the employee pays out of pocket. We already talked about those big deductibles. You add those numbers up, and that's $26,000 being paid on average, not the high end, on average, for a family of four when you add up all the dollars and cents combined from the employer and the employee. With Centivo, what we're seeing so far is savings of 20%. And those savings are coming from savings across all three slices of that pie. So employers are typically saving about 15%, and typical family of four is saving about $3,000 in total, coming from a combination of reduced out-of-pocket costs and reduced contributions coming out of their paycheck. Again, you as the employer working with your advisory team at Sterling, you can move these numbers around. If you're in a situation, we've had some employers say, you know what, my employees need a win. One of our clients is an automotive dealer, and the owner of that organization was very clear, saying, I've given my employees bad news for 10 straight years when it comes to healthcare. I'm doing okay. I've actually had a great year, and I want my employees to get a win. So they shifted a lot of the savings to the employee, and the employer saved closer to 5%. But we've had other situations where the employer said, look, this is a tough year, and I'm going to be making a call here between keeping people employed versus having to take more drastic measures, and I need to get more of those savings to myself. Again, those are the kinds of discussions, and that's the kind of strategy that a great advisor like the team at Sterling can certainly help you navigate. But either way, whoever gets the savings, it's not going into the insurance carrier's pocket, and it's not going to providers who are otherwise not being cost effective with how they spend your or your workforce's healthcare dollars. So we're going to hit a few more points here and then hopefully get into a bit of a discussion. But I want to bring a real life example from the tri-state area to life. So one of our clients is Stu Leonard's. I'm hopeful that many of you may have shopped at a Stu Leonard store. They have stores throughout the tri-state area, and those of you who are familiar will recognize the big slab of granite in front of every store that says, rule number one, the customer is always right. And rule number two, if the customer is wrong, please go back and refer to rule number one. So a really great organization in terms of a partner in always trying to do the right thing. So they had been with a traditional carrier for about 10 years, no different, I'm guessing, than most of you. They had fought through the normal increases in deductibles and coinsurance and premium, and stepped back after having spoken with other employers and really immersed themselves into the space and said, we want to do something different. We've been innovators throughout everything else that we've done in our business, and we'd like to do the same in healthcare. So through that process, they no longer work with their former insurance carrier, and they now work with Centivo as their health plan administrator. Our solution, which is a full replacement solution, allows for the high value model that we described. And here's the part that we haven't talked about yet in this presentation. Every employee had a choice to also choose a broad network, and that broad network is Cigna. So if any employee said, I needed a broader national network, or I want a network that does not include, or that includes some of the providers that were not listed on the Centivo set of partners, they had the option to choose that broader network. As you see below, about half the employees chose what was called the Prime Partnership Plan, which was the Centivo ACO model, and about half the employees chose the Broad Cigna plan. Both of those are administered by us. So you have one single throat to choke, one source of data, and absolute transparency in where your money is going, regardless of which network an employee chose. In addition, we put in other programs, and we work closely with your advisors to do this. But examples of programs that we've managed to put in outside of the providers are especially pronounced in the area of pharmacy management. So we implemented what's known as a transparent pharmacy benefit manager model. We also included what's called manufacturer copay assistance. So that allowed us to tap into dollars that are made available by drug manufacturers on high-cost drugs. You may be familiar with some of these, like Humira or Genarc. These are drugs that are increasingly coming out and costing $10, $25, $100, $250,000 a dose. Incredible amounts of money. They also add a lot for quality of life for those people who need it. But what we do is make sure that those drugs are procured at the absolute lowest cost possible. And if there are drug manufacturer dollars available, that all of those are tapped into to lower your cost and your employees' cost. So the net result is pretty staggering. And again, for those of us who've sometimes just gotten so beaten down into, if I can have my cost increase not go up 10 or 20% and only go up 5%, then that's a win. That's a good year. I'm going to take it or run. These numbers can sometimes feel hard to believe, but I'm using the Stu Leonard's as an example. These are very indicative of what we're seeing across our client base. So half the employees chose the partnership plan. Overall, we're seeing a 42% decrease in cost. 15% of that is coming from a reduction in pharmacy spend. The members themselves, the team members, so this is not a play to cost shift and save the company money by having the employees spend more. The members are seeing an 81% reduction in member out-of-pocket cost. And here's my favorite stat. And it's my favorite stat because at the end of the day, it's why we started the company. We started the company because too much of America can't afford their health care. 62% of team members on the Prime Partnership Plan have used healthcare yet have spent $0 out of pocket. So what that means is they've gotten advantage of free primary care, they've used virtual care, and so it's not that they haven't used the healthcare system, they have used it, but yet have spent $0 out of pocket. That's the kind of win-win that we all know is achievable, but sometimes can feel hard to believe. So I'm going to move along to just hit a few other details. And then we're going to be able to pause and ask questions and have a discussion, and hopefully we'll be fairly provocative. But as we hit the last few points here, and we're also going to do a short member demo, across our client base, so this is beyond just Stu Leonard's, what we're seeing is partnership plan enrollment. So many of you might be thinking, that just feels like a lot of people are not going to want to choose a plan centered around a Mount Sinai, an Atlantic, a Valley, a Catholic Health. Well, what we're seeing is 25 to 85%. So again, for those employers who have unique situations, split families, college kids, folks on certain parts of the geography where we may not have a fully built network, they always have that option with Cigna. And even in those circumstances, we see at least 25% choose the partnership plan, but in some cases as much as 85%. We've seen some very high engagement and satisfaction metrics. We're going to show you a short demo of the member experience where we'll describe what activation means, but you'll see that people are using the tools that we make available. And then last but not least, better utilization. And some of us might focus on the premiums and the increases, and that's all that matters. But in order to get those costs controlled over the long term, we need to get folks to use the healthcare system more wisely. And good examples here are a 21% increase in primary care visits. That's what I call good spend. No health plan ever got bankrupted by spending more money on primary care. A 50% increase in preventive care. That's the kind of thing that's been free for 12 years. But how many of us know of people, maybe our own family members, who just don't go get their annual well visits? We're seeing an increase there. And here's a big one that saves a lot of money, a 30% decrease in ER visits. We've all seen those crazy bills and the EOBs when people go to the ER. And the biggest leaky bucket to drive healthcare cost is when folks end up at the emergency room, when a virtual visit or a call to your primary care physician would do. So if we go to the next slide, putting kind of front and center an example of the plan benefits that our clients have implemented. And again, these are all adjustable. And the advisors, as we've talked about before, the broker consultants are a key part of defining what these values and what the structure should be. So under the partnership plan, what you'll see is free primary care visits, clear copays, and no deductibles. I like to joke it's sort of the richest plan since folks had big hair back in the 1980s. But we always make available a traditional looking option. So our message to a workforce is we're not forcing people into a plan, we're giving people an option. And if folks want a traditional PPO plan, we typically mimic or map against the current plans you have today, or a high deductible plan that's HSA qualified for those who like that. Those remain available as options. Again, Centivo is the single administrator here for you. So it's clear and simple in terms of who you go to and how the plan gets managed. When you choose the PPO or the high deductible plan with the Cigna network, the ID card has a Cigna logo on it. So it looks and feels very similar to the member, just like if they were buying their insurance directly from Cigna. So one thing if we go to the next slide, before we pivot to member experience, I should have said this at the outset, but if you have questions, feel free to enter them in the chat function. And as we go into the member demo, this will give you probably about 5 or 10 minutes to start logging your questions. Steve, Mary Alice, and I will take those questions as we come back from the demo. So definitely go into the chat function and type your questions in, and we will take them in the order received. So the next part we'll go into is obviously leg one of the stool is save money. There's no point in changing something unless you can get the kind of savings that we've proven to get. The second leg of the stool is to make sure that people get really great healthcare. And hopefully we've described to you how we do that, working with really high quality partners. The third leg of the stool then is, well, how do you make it easy, right? The last thing that we all want to do is spend our whole days navigating a health insurance change. And the last thing we also want is for employees to feel like 3 or 4 months into the plan year that the experience is not going the way that they might have wanted to. That's just going to lead to a lot of grief for everybody. So we've organized the plan and the experience to keep it really simple, really affordable, both at the doctor as well as when you use the health plan. And one of the things I'm really proud of is because we work with a set of providers, these high quality, high value, cost-effective providers, we're able to get them to do things that the big insurance carriers are simply too big to get their attention on. I'll give you a good example. A client of ours on Long Island, a manufacturing company that develops sort of dermatology type products, the wife of one of their team members needed to get into an OB-GYN, needed to happen fairly urgently. We were able to make a couple phone calls, and within the next day, we're able to get someone to see an OB-GYN in Hicksville at ProHealth easily, conveniently, and that led to a kind of satisfaction that is just too absent from the way healthcare works today. So with that, Jamil, I'm going to turn it over to you to walk through a short demo of our member experience on the technology side. And again, it would be great if folks can enter questions in the chat so we can have a discussion as we come back from the other side.
Great, thank you, Ashok. Hello, everyone. Pleasure to meet and present to you today. So what we're going to view today, as Ashok has mentioned, is the member experience demo once a member has enrolled in our partnership plan before the plan effective date. So for today's demo, we're going to be Serena. So Serena receives a notification that she needs to activate, which is essentially creating an account and selecting her primary care team. In the beginning of the activation process, we're going to provide some basic information to Serena in regards to what the partnership plan is and what activation means, when it's useful to use the primary care team, as well as general information on referrals and specialist visits. Serena is then prompted to select a primary care team for herself and her dependents. And so what we've built here is a unique tool for members to select that primary care team based off of preferences. So first, we provide the availability for the member to select or search for primary care teams based off of the distance, any specific preferences or specialties that that member might be interested in, as well as any gender preferences. We'll then provide a list of primary care teams for that member to learn more about that clinical support team and that physician to see if it suits their needs. So Serena here can view more information about Dr. Michael Carlisle. She can see where Dr. Michael Carlisle is located, as well as any pertinent information related to that specialty and that location. In most cases, Serena will select the same primary care team for his or her dependents. So once the member has selected their primary care team, we provide 2 call to action buttons. And really these are informational call to action buttons to ensure that the members truly understand what the primary care, what the partnership plan is about, and so that they can get the full use out of it. So with the first call to action button, we provide information on when it's useful to start with your primary care team, when it's applicable to go to urgent care, when it's applicable to seek hospital or emergency room care, as well as when you would need a specialist. And then also providing additional information that this is an in-network only coverage plan and out-of-network coverage isn't provided. So we then provide a brief quiz for the members to take so that they can truly understand the plan. So here Serena sprains her ankle, what would she do? And she would seek care from her primary care team. When should you go to urgent care? And it would be when your primary care team is unavailable. Then next, for the second call to action button, it's really surrounding the overall plan details and making sure that the member understands the plan designs. So in our full transparent model, just making sure that the members are fully aware that this is a no deductible free PCP plan, along with that transparent, predictable copay schedule. We also provide basic insurance terminology to make sure that the members are aware of key terminology, such as deductibles, out-of-pocket maximums, as well as what a specialists are, as well as referrals. So next, how would you pay for your visit to your primary care team? And again, reinforcing the fact that all primary care team visits are free. And for coordinated care, there would be a predictable copay. So that's essentially the first part of activation. Next, we're going to view the member experience for the year-round usage. So here, through the messages icon, this is where referrals will be coordinated with the member as well as the primary care team. Members can elect for referrals through the app where the PCP can either approve or deny. And you can see here that the referring provider, Dr. Michael Carlisle, has approved Nicole, the orthopedic specialist that the member wanted to see. We also provide a tool for members to access our directory where they can view any health professionals as related to any specialists that they may need. Important to note that for behavioral health and OBGYN, referrals are not required. In addition, through the app, throughout the year, members and their dependents can view their cost history and cost care with the accumulators that we provide. We also provide the availability for members to have their digital ID card. We also will mail physical ID cards, but we understand that in today's world, technology is becoming more of a connectivity with our members. So we have the ability for members to save their digital ID card to their wallets or share it with their dependents. And then lastly, we also provide the accessibility for members to contact our concierge team, which has no phone trees, and members can be directed directly to someone to assist with any needs that they may have. They can also send us a message through the app, whereby they will also receive that communication through the messages center. So now I'll pass it back over to Ashok.
Thanks, Jamil. And if you could actually stop sharing your screen, I'm going to wrap up the presentation with 2 last slides, and I'm going to show something from my desktop because I think it's a good way to close. So again, and hopefully we'll have some Q&A and some discussion here, but you know, a lot of folks ask, how is this possible? Like, how is it possible to save money, enrich benefits, and do so in a way that doesn't break the bank. It just can feel hard to believe, and people have been sold all kinds of things over the years. What I like about this, and again, having been in this space for a long time, is it starts with some very basic principles around how healthcare is purchased, consumed, and sold. And so we directly confront 4 key myths in healthcare that have prevented us from breaking through the clutter. The first myth is you can't enrich AV. AV is actuarial value. How much does the plan cover? That you can't enrich it without simply spending more money. Well, the reality is by shifting care from higher cost to high value providers, that can save up to 50%. And if you save up to 50% on healthcare, you can certainly make the plan richer. And I'm going to show you that on the last slide. The second is BUCA, which for those of us in the industry know stands for Blue Cross, United, Cigna, Aetna, basically the 4 large carriers, has the best discounts because of its scale. Well, Centivo has shown that we achieve 10 to 15% better unit costs due to how we do our contracting. And one of the things that, as you work with the team at Sterling to help determine, is you don't have to take our word for it. You don't have to trust us. We partner with leading carriers of stop loss reinsurance where they price the contracts that we have and pass the savings on in the form of lower insurance premiums and lower aggregate attachment points. So there's real black and white dollars and cents behind the claims that the costs are better under the Centivo contracts. The third myth is employees won't want to choose a plan that doesn't have a provider directory that's as thick as Empire or Horizon. And the reality is we've shown 25 to 85%, but mostly 25 to 40% for most cases on a slice basis, which is when that's made available as an option next to those traditional broad plans that are also made available to your employees. And then last but not least, well, this all sounds like a lot of work. Can we just move people to use more high value care inside the networks that they're in? Well, it doesn't work. And the reason it doesn't work is because people do what their doctors tell them to do. So this is going to be my last slide. And then Steve and Mary Alice will turn it back to you and we'll have a discussion and some Q&A. But I just wanted to put right front and center the cost differences in healthcare. In the New York market, we have the exact same slides for New Jersey, for Connecticut, and elsewhere. But Hospital A, B, and C is part of the Mount Sinai system, our partner. Hospital D is NYU, and Hospital E is New York Presbyterian. They're all great institutions. This is not about saying that Hospital D and Hospital E are not good hospitals. They're very good hospitals. But look at the cost differences. So this is an average rate paid by Blue Cross, United, Cigna, Aetna in this market for the top 10 procedures that are done at a hospital, what's known as a DRG, or a diagnostic related group. The average rate at Mount Sinai is anywhere from $23,000 to $28,000. The average for those exact same procedures at NYU is $37,000, and at NYP is $51,000. And then if you take into account the enhanced contracting and the lower rates that Centivo's getting by taking out the carrier middle person and directly negotiating with these hospitals, you see the difference of about $19,000 to $20,000 versus $40,000 to $50,000. 95 to 168% savings for these high cost hospital procedures. Those get translated back to you in the form of lower stop loss premiums, lower costs year over year on total cost of care, and the ability to enrich your benefits for your workforce. So with that, my section is wrapped up. And Jamil, maybe you can pull up the discussion slide just so we have it up there. But Steve and Mary Alice, I'm going to turn it back to you. And once again, I appreciate everybody's time. And I know this is not a typical carrier conversation or a health plan conversation, but hopefully have been a little bit provocative and have opened people's minds up to what's possible in terms of restoring affordability to your health plan.
Thank you, Ashok. One question I wanted to ask, and I know that Centivo is not a stagnant organization, and I wanted to just see if you might be able to discuss what Centivo is doing going forward to expand your footprint across the country?
Yeah, it's a great question, Steve. So just to give you a flavor of that, I mentioned earlier on that we are now in the process of, we're either live or are building out markets. So we'll be in 16 MSAs by January 1st of 2022. Just to put that in contrast, we were up in 6 MSAs for January 1st of 2021 and 3 MSAs on January 1st of 2020. So we have been rapidly growing that footprint around the country, and then of course offering that option through Cigna for folks who have employees in other places. The way that we have been building out those markets usually happens with one of two things. The first is we will have provider groups come to us and say, we hear about what you're doing, and we want to do more of that. We want to do what Disney did, but it's hard for us to get to market as a provider system. And so a good example is Dallas. We're right now in discussions with one of the largest systems in the Dallas market and expect that to be up and running by January 1st of 2022 because they're looking for a partner like ours to roll out this model. A second example is when we'll have a large employer come to us, or a set of mid-sized employers come to us and say, we really like this. Would you be willing to work with us to build out this mousetrap? And so an example there is what we're doing in the state of Wisconsin, where we're building out a provider network, and we're actually partnering with 8 of the largest employers in Milwaukee to make that happen. The last part, Steve, I'll say, and then I'll pause, is it's also not stagnant inside of the markets that we're in today. So a good example would be, we initially had urgent care through our health system partners, but we added CityMD earlier this year, which obviously expanded the footprint in a pretty significant way. From a Connecticut perspective, we had some of the hospitals, but we've substantially added GIs and orthopedics and dermatology and a number of the other specialists, again, given the clients that we've added, in the Connecticut market. So to your point, not stagnant, constantly growing and very dynamic.
Thanks, Ashok. Ashok, I think another area that is important and employers may not see it today, or it happens behind the scenes a little bit, is Centivo's strong relationship with the stop loss market, stop loss outlets that you have and partners that you have. I think it's very important to point that out as well, that due to the relationships that you have, that the stop loss market could be an advantage as well to employers.
Yeah, it's a really good topic, and Steve, I'm going to spend. Let me sort of take a slight detour, and then we'll come to directly address your question. So I'm imagining some of the employers on the call are self-funded today, are very familiar with stop loss. Some are self-funded, but maybe through a carrier, and therefore it still kind of feels like a bundled solution through that carrier. And then some may be fully insured and don't sort of fully recognize the nuances of stop loss. So the first thing that's most important in this category is you need an advisor who, if I may be so direct, knows what they're doing in the area of risk management and the area of stop loss. So we're very comfortable with the team at Sterling. Obviously, there are other great ones as well. But one of the reasons many employers don't entertain going self-funded and saving money by doing so is because they often get bad advice, to be that direct. And so what I'd urge all of you is to make sure you have the right advisor. Many of you already do, working with Sterling, but for those who don't, make sure you actually have an advisor who's representing your interests and can understand the flexibility and the nuances of the different arrangements that are available. That's first and foremost. Most clients that we find that are over 100 employees over any period of time will save money by being self-funded, but many get advice from their advisors that they shouldn't do it, that is too risky. Well, here's why it's not risky. Why it's not risky is because no employer goes self-funded and is naked. Employers add to their plan a stop loss program. There's 2 types of stop loss, as most of you know. One is called specific stop loss tied to individual high claims, and the second is called aggregate stop loss, which is really an umbrella policy for the overall plan. What the stop loss carriers do with us, Steve, now getting really to your direct question, is they look at the fundamental contracts that we have in all of our markets. They look at UCLA and LA, they look at Mount Sinai, New York, Atlantic Valley, Catholics, et cetera. And they basically do a very simple math calculation because they're on the hook for large claims. So they say, and it ties into that last chart that all of you saw, if somebody has cancer and ends up at NYP versus Mount Sinai, it's going to cost them 2.5 times more. So they run that through a formula of how many cancers do they expect in a population of what type. And based on that, that has to be compensated for either through higher premium or for the need for more of a risk corridor in the form of a deductible or the aggregate attachment point. So what we've done to bring that to life is we've partnered with a number of stop loss carriers. Some of them are established firms that have been doing this for a long time, like Sun Life and Berkeley, and others are more innovative companies. And the best example I'd cite there is an organization called Granular Insurance, which is a joint venture between an old line insurance company, Swiss Re, and a new line, if that's a phrase, tech company that you've all heard of called Google. And so Google and Swiss Re have come together to create a stop loss carrier that is based on data and analytics and projections. And whether it's through one of the traditional carriers or one of these new ones, we typically find substantial savings in both the premium and the aggregate factors because they're reviewing the contracts which drive the ultimate liability that they all have.
Great, thank you, Ashok.